I want you to imagine something for a second. It sounds like a superpower, maybe something out of a Christopher Nolan movie. Imagine being able to freeze time. Not in a, stop and smell the roses kind of way, but literally stopping a high-speed event in its tracks just to see what's happening.
It does sound like sci-fi, but in my world, that's just...
Well, it's called stroboscopy.
Exactly. And that is where we're starting today. We are doing a deep dive into the human voice, specifically the larynx. We're going to look at how doctors use light to, freeze time, how they diagnose what goes wrong in our throats, and then we get into some pretty heavy, high-stakes territory, laryngeal cancer.
Yeah, and the surgeries that literally replumb the human body.
Replumb is the perfect word. Because when you look at the source material we have, these surgical guides, the oncology protocols, it's amazing how mechanical it all is. It's all about airflow and valves and pressure.
And vibration.
Right. But let's go back to that time freezing thing, because I was reading about stroboscopy and I had a genuine aha moment. It all starts with the speed of the vocal cords. It does. I mean, when you speak, your vocal folds are vibrating. And not just a little bit, we're talking at least 100 times a second.
100 times. And if you're singing a high note, it's what? Much more.
Oh, hundreds of times a second, which creates a huge problem for a doctor.
Because if I just open my mouth and you shine a flashlight down there, you're just going to see a blur.
A complete blur. It's just physics. The human eye isn't fast enough.
The sources mentioned Talbot's Law here.
Yes, Talbot's Law is the reason. It basically says an image stays on your retina for about 0.2 seconds. So if the vocal cords are moving way faster than that, and they are, your brain just smears all those images together. You can't see the edges, you can't see texture.
And you certainly can't see a tiny early stage tumor.
Not a chance. So that's where the stroboscope comes in. This is the magic trick.
It's essentially a strobe light like at a dance club, but way more sophisticated.
Much more. It's a synchronized flashing light, and it's passed through a flexible telescope. The key is that the flashes are incredibly short, a fraction of 10 microseconds, and they're perfectly timed to your voice.
So if my cords are vibrating at 100 hertz.
The light flashes at 100 hertz, or slightly off phase if we want to create a slow motion effect. It's an optical illusion. By lighting up the cords at the exact same point in their cycle over and over, your eye is tricked. It thinks they're frozen still.
Wow. And that lets you see the wavy movements they talk about?
Right. You can actually see the mucosal wave. You can see if a section is stiff or if there's a tiny lesion that isn't vibrating properly. That frozen moment is often the first time a doctor thinks, uh-oh, that looks like early glottic cancer.
And that's the pivot point of this whole thing. We go from cool physics to the very, very serious reality of malignancy. Because once you see it, you have to prove it.
And proving it means a biopsy. The gold standard is direct laryngoscopy. You have to physically go in and take a sample.
Okay, now this is where the source material gets into a debate that I found really intense. It's about anesthesia. You can knock the patient out completely with general anesthesia, or you can try to do it with local while they're awake.
There is a choice, yes, but if you look at the protocols, it's not much of a choice. General is overwhelmingly preferred.
I would have thought local was safer. You avoid the risks of being put under.
And for almost any other part of the body, you'd be right. But the throat is different. The throat is the guardian of the lungs. It is incredibly sensitive. If you poke it, if you irritate it, it reacts violently.
Laryngospasm.
Exactly. It's a terrifying word. It's a protective reflex where the vocal cords just seize shut.
So if you're in there doing a biopsy with local and you accidentally, nick a blood vessel or something?
Or just irritate the tissue, the cords can cramp down and they don't just close a little bit, they lock. And suddenly your patient cannot breathe. It is a full airway obstruction.
And the risk factors here, obesity, smoking, COPD, are the exact same people who are most likely to need this biopsy in the first place.
Precisely. So if a patient with bad lungs has a laryngospasm, their oxygen levels plummet. The protocol to fix it is, it's aggressive. 100% oxygen, muscle relaxants.
Or, in the worst case scenario, an immediate tracheostomy.
Which you never want to do during a diagnostic procedure. You don't want to be cutting a hole in the neck just to get a sample. That's why general anesthesia is the safer bet. You paralyze the muscles proactively so they can't spasm.
So we've frozen time, we've got the patient safely under, and we've got our biopsy. But there's another layer of investigation, imaging, and those are so specific here. CT scans with the 1mm cuts.
This is absolutely crucial. You can't just send someone for a standard chest CT. You need those 1mm slices.
Why? Why that level of precision?
Because the larynx is a game of millimeters. We're not just looking for a tumor, we're looking for cartilage erosion. We need to know if the cancer has eaten into the thyroid cartilage. But even more importantly, we have to know if it's subglottic.
Meaning below the vocal cords.
Yes. If that tumor extends more than 1 centimeter below the vocal cords, the entire treatment plan changes. And you can't see that with a scope. You need those thin slice CTs.
And the MRI is just sort of backup.
It's additive, it's better for soft tissue, so it helps us see if the preepiglottic space is involved. But that 1mm CT, that is the surgeon's roadmap.
Okay, so let's talk about the destination. Treatment. It seems like there's this constant tension in the field between two big goals. Saving the life versus saving the voice.
That is the central conflict. I mean, if we only wanted to save a life, we'd just rip the whole larynx out every single time. It's the safest move oncologically, but the cost to the patient's quality of life is just astronomical.
So if we catch an early stage T1 or T2, we try to be more gentle.
Right, we call it organ preservation. We can use lasers to very carefully carve out the tumor, leaving the rest of the cord, or we use targeted radiotherapy. The goal is a cure and a working voice box.
But then the text shifts, T3 and T4, advanced cancer.
This is where the tumor's big. Maybe it's fixed in vocal cords so it doesn't move. Maybe it's eating through the cartilage. Here, the conversation shifts from saving the voice to managing the damage.
Before we get to total removal, there's this middle ground. Conservation laryngectomy. I found this fascinating. It's like architectural remodeling of your throat.
That's a great analogy. It's surgery for cancer that's too big for a laser, but maybe not big enough to justify taking the whole organ.
Like a vertical partial.
A hemolaryngectomy. So imagine the larynx is a box. In this surgery, we basically take off one side of the box, one vocal cord, half the thyroid cartilage.
And the patient can still talk with half a box.
They can. It's coarse, but it works. The trickier one, though, is the horizontal supraglottic laryngectomy.
That's for cancer, that's higher up, right?
Correct. Supraglottic means above the cords. So here, we cut off the top half of the larynx, we take out the hyoid bone and the epiglottis.
The epiglottis, that's the little flap, the lid that closes when we swallow.
Exactly. It's the trapdoor that keeps food out of your lungs.
So if you remove the trapdoor,
you create a massive risk. Every time that patient eats or drinks, they're at risk of aspiration food going down the wrong pipe.
Which explains the strict prerequisites. It says adequate pulmonary reserve.
Which is doctors speak for, you need to have really strong lungs. Because you are going to choke a little bit while you relearn how to swallow. You have to be able to cough violently to clear your airway. If you have weak lungs from smoking, you can't have the surgery. You'd get pneumonia and you would die.
So if your lungs aren't strong enough or the cancer is just too big, we arrive at the radical solution, total laryngectomy.
The nuclear option. It was first performed by a guy named Theodore Billroth back in 1873. It's one of the oldest major cancer surgeries we have.
The description of the procedure is, it's intense. The apron flap.
The Gluck-Sorensen flap. Yeah. It's a huge U-shaped incision from ear to ear, dropping down. They peel the skin up to expose the entire neck.
And then they just take everything.
Everything. The hyoid bone, the strap muscles, the thyroid cartilage, the cricoid, the vocal cords, the entire voice box is removed.
But the part that is hardest to wrap your head around is the disconnect. Right now, for you and me, our windpipe and our food pipe are connected.
They share a hallway, right? In a total laryngectomy, we permanently divorce them. The trachea of the windpipe is cut and it's bent forward. The surgeon sews the open end right to the skin of the neck.
Creating the stoma.
A permanent hole. You breathe through your neck for the rest of your life. You never breathe through your nose or mouth again.
Which means no sense of smell.
Correct. We smell things because air carries particles past the nerves in our nose. If air isn't moving through your nose, you don't smell. No coffee, no flowers, nothing.
And obviously, absolute silence. No vocal cords.
The silence is profound. And it's not just physical, it's psychological. That's why the text hammers on preoperative counseling so much.
It even suggests meeting a fellow laryngectomy.
Oh, it's vital. Imagine being told you will never speak again. It's terrifying. Meeting someone who's had the surgery, seeing them breathe through a stoma, but still, cracking jokes or ordering a coffee, that visual proof of life is part of the treatment.
And that brings us to the reconstruction. Because we don't just leave them in silence. We have ways to build a new voice.
We do, and this is where human ingenuity really, really shines. There are three main ways.
First, there's the robot voice, the electrolarynx.
The device you hold against your neck, it vibrates the tissue and you mouth the words. It's reliable, it's easy to learn, but it sounds mechanical.
Then you have esophageal speech.
The burping method.
Is it literally burping?
Mechanically, yeah. You swallow air, you trap it in your esophagus, and then you force it back up. The migration of that air creates sound, but it is incredibly hard to master. The sentences are short and choppy.
But then we have the game changer, the TEP.
The tracheoesophageal puncture. This is the gold standard today.
So how does the plumbing work on this?
Okay, so remember that disconnect. Windpipe and food pipe are separate. The surgeon takes a needle and makes a tiny puncture between the back of the windpipe and the front of the esophagus.
Reconnecting them.
Sort of. They put a little one-way valve in there like the Blumsinger prosthesis. It lets air go from the lungs into the food pipe, but it stops food from falling back into the lungs.
So to talk, you just breathe.
You take a breath, you cover the stoma with your thumb to block the exit, and then you push. The air has to go somewhere, so it goes through that little valve and into your esophagus.
And that vibrates the throat.
Exactly. It vibrates the walls of the pharynx. And because you're using the full power of your lungs, you can speak in long, flowing sentences. It's a deeper voice, maybe a bit gruffer, but it sounds human.
There is a specific surgical step mentioned here that seems critical for this to work. The cricopharyngeal myotomy.
Oh, it is key. So at the very top of your esophagus, there's a muscle, the cricopharyngeus. Its job is to stay tight.
But for TEP speech, we need the air to pass through that spot.
We need it to be relaxed. If that muscle is tight or spasms, the voice gets stuck. You're pushing air, but nothing's coming out.
So the surgeon just cuts the muscle.
Yep. During the laryngectomy, they just slit that muscle down the back. It relaxes the mouth of the esophagus so air can vibrate freely. It's a small detail, but without it, the whole system fails.
For as heavy as this topic is, the loss of the voice, the hole in the neck, the prognosis section was surprisingly hopeful.
It is. If you look specifically at glottic carcinoma cancer on the actual vocal cords, the 5-year survival for stage I is 90%.
90%? That's incredible. Why is it so much higher than other cancers?
Two big reasons. First, the vocal cords are snitches.
Snitches.
They tell on the cancer immediately. Even a tiny tumor ruins the vibration. Remember the strobe light? It makes you hoarse, you sound terrible.
Yeah.
So patients go to the doctor early.
And the second reason?
Anatomy. The vocal cords are basically in a lymph node desert. They have very, very sparse lymphatic drainage.
So the cancer doesn't have a highway to spread on.
Exactly. It gets trapped in the box, it grows slowly, and doesn't metastasize quickly. That gives us time to use the lasers or the radiation and get a cure.
It really is a full circle. We start with the physics of light, letting us see an invisible vibration. And we end with re-engineering the body to create a vibration where there is none.
It's a testament to adaptability. The human drive to communicate is so powerful that we will literally learn to speak with our digestive tracts if we have to.
And that leads me to the final thought I want to leave everyone with. We spend our whole lives identifying with our voice. It's how we sound to our family, our partners. It feels like us.
It does.
But we've just spent all this time breaking down the fact that the biological machinery of the voice, the cords, the cartilage, can be completely removed. It can be replaced by a plastic valve and a slice of your esophagus. And yet, these patients are still themselves. They still tell their stories.
It really makes you question what a voice actually is.
Exactly. Is your voice the anatomy? The biology? Or is your voice the intent behind the words? Because looking at these surgeries, it really seems like the biology is negotiable. But the need to connect, that's what's permanent.
That's a powerful way to look at it.
Thanks for diving deep with us into the anatomy of silence and sound. We'll catch you on the next one.